Hello everyone. Thank you for attending my presentation. Today I would like to share our experience with AI software implementation to improve ICSI performance, focusing on its workflow and clinical outcomes. First of all, it is well known that sperm quality directly affects fertilization and embryo development. In particular, morphology of the sperm head, midpiece, and tail, as well as motility, have been associated with outcomes such as fertilization rates, blastocyst formation, and even pregnancy success. Several studies have shown that abnormalities in these areas can negatively affect ICSI results. This slide shows the limitation of manual sperm selection in ICSI. It mainly depends on the embryologist's experience and personal judgment. In particular, motility is hard to evaluate in a consistent, objective way. This can lead to variation in selection, which may affect fertilization and embryo development. The AI-based system SIDO may help solve these problems. But SIDO was designed by IVF 2.0 Inc. to assess sperm motility in real time and help select sperm suitable for ICSI. It was trained on the motion characteristic of sperm that successfully fertilized oocyte and developed into blastocysts. Evaluates key parameters such as straight line velocity, linearity, and head movement pattern. They are combined into a single score that reflects sperm quality and supports consistent sperm selection during ICSI. SIDO evaluates the motility parameters of sperm in real time within the microscope field of view. The top 3 sperm are identified using best for green, good yellow, medium orange. They are further ranked in order as A, B, and C from highest to lowest, as the embryologist confirms the final sperm selection. This approach helps to minimize ethical concerns about relying solely on AI. We introduced SIDO in our clinic to improve ICSI outcomes, and in the following slides, I'll share an overview of the clinical outcomes. Before applying SIDO clinically, we first conducted a pre-study, which we refer to as Study 1. In this study, we examined whether sperm selected by embryologist or by SIDO were capable of binding to hyaluron. As sperm that can bind to hyaluron are reported to be functionally mature and exhibit low levels of DNA fragmentation. We also tested it with donated oocytes and confirmed there were no problems. Following this, we performed a study to respectively evaluate clinical outcomes of ICSI using sperm selected SIDO versus those selected by embryologists. This slide shows how sperm were selected in the embryologist group. Embryologists selected sperm based on motility and morphology. For example, progressive and stable motility as well as normal head shape and tail structure were considered favorable. Sperm with abnormal movement patterns or irregular morphology, such as bent tails or double heads, were avoided. This slide shows how sperm were selected in the SIDO group. This SIDO evaluates motility characteristic and assigned a score to each sperm in real time, and we selected rank A sperm, categorized as best for ICSI. This slide shows the design of Study 1. We evaluated sperm binding ability using the hyaluron binding assay. Sperm were individually placed into a pixie dish coated with hyaluronic acid, and their binding ability was assessed. We compared 4 groups, junior and senior embryologists, each with and without the support of SIDO. In this study, a junior embryologist was defined as having 1 year of ICSI experience and a senior embryologist as having 10 years of ICSI experience. This slide shows the design of study 2. We compared ICSI outcomes using sperm selected either by embryologist or by the shadow. We assigned each case to either the control or shadow group. After PSXC, embryo were cultured with time-lapse incubator, and we analyzed fertilization outcomes, blastocyst development, and morphokinetics. This graph shows the patient background such as female age, AMH level, or BMI between the two groups. There are no significant differences between two groups. This slide shows the result of the hyaluron binding assay in study 1. These two bars shows senior embryologist. Blue is senior embryologist without shadow. Red is senior embryologist with shadow. These two bars shows junior embryologists. Green is junior embryologist without shadow. Yellow is junior embryologist with shadow. Junior embryologist without shadow was significantly lower than that of senior embryologists. However, when the junior embryologist used shadow, this difference was eliminated, and they achieved comparable results to senior embryologists. This slide shows fertilization outcome from study 2. As you can see in this graph, the rate of 2PN, 1PN, and 3PN were comparable between the control and shadow groups. There were no statistically significant differences in fertilization outcome. This slide shows the blastocyst outcomes from study 2. The blastocyst formation rate was similar between the two groups, and the difference was not significant. The embryo utilization rate was 41.5% in the control group and 48.8% in the shadow group. Although slightly higher in the shadow group, this difference was not statistically significant. This slide shows the embryo morphokinetics from study 2. We compared the timing of embryo development between the two groups. We found no significant differences, indicating the developmental kinetics were similar regardless of the sperm selection method. Here, the outcomes of the shadow group were comparable to those of the embryologist group. However, differences between cases may have influenced the results. Therefore, we conducted additional analysis using only sibling oocyte to minimize patient variability. This slide shows the design of our sibling oocyte study. In this analysis, mature oocyte retrieved from single patient were equally divided into two groups. One group underwent ICSI using sperm selected by shadow, and the other using sperm selected by senior embryologist. All ICSI procedures were performed using the ICSI method. We compared fertilization and blastocyst development outcomes between the two groups. We excluded any case using frozen sperm or AOA, and PICSI and MG. The fertilization outcomes, including 2PN, 1PN, and 3PN rates, were similar between the two groups, consistent with our previous findings. However, the blastocyst formation rate was significantly higher in the shadow group, 74.8%, compared to the control group, 66.4%. In addition, the good quality blastocyst rate was also significantly higher in the shadow group, 48.2% versus 40.1% in the control group. Blastocyst outcome from our senior embryologist met the benchmark standards defined by the ICSI consensus. These results suggest that using shadow may help improve blastocyst development outcomes. A study from Canada similar to ours evaluated Shido during ICSI using a civil oocyte design, comparing sperm selected by Shido and by embryologists. Although the differences were not statistically significant, Shido shows higher blastocyst outcomes. These results, along with ours, suggest that Shido can perform as well as or even better than experienced embryologists. This slide summarizes our findings from study 1 and 2. Shido can assist junior embryologists by reducing variability in sperm selection and enable consistent reproducible performance comparable to that of senior embryologists. Shido may also help shorten the training period required for ICSI. Shido enables high-quality sperm selection by analyzing motility patterns that are difficult for embryologists to assess, potentially improving embryo development outcomes. Thank you for your attention. I would like to thank Kitazato Corporation for the opportunity to present today. Thank you.